support for BCI is strong in our oncology world. It's been incorporated into both the NCCN and ASCO guidelines. And here you see the verbiage for both. So we'll start with the left side of the screen, the NCCN guidelines. They state that those who had a high biomarker value demonstrated significant improvements in disease-free survival when adjuvant endocrine therapy was extended. And then those who had a low value for their biomarker demonstrated a lower risk of distant recurrence and were unlikely to benefit if therapy was extended. And then on the right side, you see the ASCO guidelines. They state that BCI may be offered to patients with 0 to 3 positive nodes who receive 5 years of endocrine therapy without evidence of recurrence to guide decisions about extended endocrine therapy. And I also think it's worth pointing out that within these same guidelines, it was noted that Oncotype and EndoPredict and Prosigna, and then also the Ki-67 and the IHC4, they were identified as having insufficient evidence to guide decisions about extending endocrine therapy. So only BCI is really supported in the space for this decision. And here we see some of the genomic assays that have been incorporated into the practice guidelines for NCCN in that breast cancer space. I think we're familiar with all of them. Okay, they include Oncotype, Mammaprint, Prosigna, EndoPredict, and then at the bottom of the screen, you see breast cancer index. And you can see that while all of these tests are prognostic to a certain extent, okay, they're all giving us information about some kind of risk. There are only 2 tests that are predictive, and that's Oncotype and BCI. And Oncotype is predictive of the benefit of chemotherapy only, and breast cancer index is predictive of the benefit of extension of endocrine targeting therapy only. And this is supported by level 2A evidence. Next slide.
So the test, breast cancer index, which is now incorporated into guidelines, it didn't get there easily. You know, being incorporated into ASCO and NCCN guidelines is a very high bar. And so the test has been around for several years, but has accumulated robust data, including thousands of patients, 4,500 patients across validation trial after validation trial after validation trial. And so finally, 2022 was incorporated into the guidelines. And this is a snapshot all on one slide of 5 validation trials. So there was initially the Stockholm trial, which included 600 patients treated with tamoxifen or no therapy at all. And so it was an old, proof of concept trial. This is not the way we treat patients, obviously now. But when breast cancer index was applied, you could see that in the yes group, there was a 65%, so a 2/3 relative risk reduction in metastatic recurrence with the use of endocrine therapy, tamoxifen. Now, moving on across the slide, you'll see how we give endocrine therapy now. So there's MA17, which was a trial of tamoxifen for 5 years. And then if patients were disease-free, they were randomized to receive aromatase inhibitor or placebo for another 5 years. This trial, the validation set included about 250 patients. And again, we're seeing when you apply breast cancer index and you get that yes result, that there's a 65%, a 2/3 risk reduction with continuing endocrine therapy, continuing on to the aromatase inhibitor for another 5 years. What's more is that if there is a no, there is no benefit. This was seen in TransAtom, which was a 5 years of tamoxifen, followed by either 5 years of tamoxifen or stopping. The IDEAL trial, which for the first 5 years included tamoxifen, aromatase inhibitor, or a sequence of both, followed by aromatase inhibitor for 2.5 years, or aromatase inhibitor for 5 years. Again, we're seeing that relative risk reduction of about 60%. And that's, what really struck me about the IDEAL trial is that one would think that it would be difficult to see a difference between 2.5 years of treatment and 5 years of treatment. But the biomarker, the breast cancer index test, was able to make this distinction and really pick out those patients that would benefit. B42 was another trial with very large validation set of about 2,200 patients that for the first 5 years received aromatase inhibitor or tamoxifen followed by aromatase inhibitor, randomized to receive aromatase inhibitor for 5 years or placebo for 5 years. And again, we see this 2/3 relative risk reduction. So while there were a variety of endocrine therapies, so tamoxifen, AI, or both, and the patients had varying nodal status, node positive or node negative, what was consistent was that if the BCI was yes, you had a 2/3 risk reduction in recurrence, metastatic recurrence, with extending endocrine therapy another 5 years, versus no benefit if you extended therapy if you received a BCI no. So what this is telling us is that risk is not equal to benefit. And Katie touched on this, just because a test is prognostic doesn't mean it's predictive. So as practitioners, we like to look at what's in front of us to help us make decisions. And so what is that? It's the pathology report, which reminds us of a patient's tumor size, grade, nodal status. We look at the biomarkers on the path report, which include estrogen receptor, progesterone receptor, and 40% or 90%. So that's the quantitative ER and PR, and try to draw information from that, as well as the Ki-67 index, which is the marker of cell proliferation, CTS5, which incorporates patient and tumor-specific factors into a risk calculator, as well as other genomic assays, right? Wouldn't it be great? You already sent the oncotype several years ago to determine whether chemotherapy would have any benefit. Can't you use it for this purpose? And the short answer is no, you can't. You can't use all of those things. They can, those clinical pathologic factors can give us information on prognosis, but they cannot predict the benefit of whether or not it's helpful to continue endocrine therapy. And that's why in the guidelines, only breast cancer index is positioned here as a genomic assay that can predict the benefit of extending endocrine therapy.